Assalamu alaikum. Good afternoon, everyone, and welcome to our weekly academic activity. Today we will have two lectures. First one is about anatomy and pathophysiology of tricuspid valve and pulmonary valve. It will be presented by Dr. Hamid Al-Salboud. And the second will be latest guidelines for the tricuspid valve by Dr. Riyad Al-Hafi. We were supposed to have a third lecture with Dr. Zuhair Al-Halis, but unfortunately he apologized because he's in the OR. So his lecture will be rescheduled to another time. We are glad to have Dr. Faisal Al-Amri, who's a consultant cardiac surgeon at King Faisal Specialist Hospital in Riyadh, as a guest for our meeting today. We'll start with an announcement, and I think some important issues to be announced by Dr. Farid Khoubir before starting our activity. Dr. Farid, if you are.
Assalamu alaikum.
Assalam wa rahmatullah.
Try to see where's my presentation here. Not sure where is it. Screen.
Dr. Farid, we don't hear you.
I'm trying to find out the presentation. Where is it? But it looks like, anyway, we'll see.
Okay.
We'll keep it like this. Share. Okay. Can you see my slide? Can you see my screen?
Yes.
What do you see here? Do you see something about learners?
Yes, exactly.
Okay. So you got, this is regarding the formative assessment exam. The learners, the number of learners who have logged in is 20 out of 50. 30 have not logged in yet, and they should have received an email today indicating that please log into the system so you can start your process. You need to answer at least 5 questions every day, correctly, every day, to be able to finish the program in time. So if you spend about maybe 10 minutes or 15 minutes, you should be able to do that. You only are left with now something like 3 weeks. So please, everybody should strive to do that. Same letter have been sent to program directors, so they are aware of your activity and your participation. Okay, the second slide here is showing that what I just told you, and it also through this program we can see the different activities by certain days. So in one weekend it was like more than 13 people working on the program. In the beginning, only one person per day were according to the dates of activity. So we do have very close tab on this and reporting. The total activity of the whole group, and please, if any of your colleagues did not reach that, make sure that they are aware of it. The total number of the activity is only 11%, and that is 50 times 100. So we're talking about something like 5,000 responses. Only somewhere around 50 responses have been received so far. This is the beauty of the program. It can give us a global picture about the residency program and how is it doing. Just to look at these color codes, 50% of the responses so far were conscious competent, which means that they are aware that they are correct and they have actually were correct on the answers. On the opposite, totally opposite, is the red one, which they think they are correct, but they are answering it wrong. So this is false confidence. It means that you are, with this kind of mentality, you're liable to make big mistakes in your with your patients. So something to be aware of. Here are somebody who's not sure. And this, can you see my mouse moving?
Yes, doctor.
Okay, so this group here of answers are not sure and got it wrong, and not sure and got it right. Okay, all right. And we can define this for the whole group, but also we can define it per the trainees. So those are some trainees that have answered, and you can see, for example, this trainee have got all the answers wrong. Half of it is with confidence, unfortunately, and some of them, and the other half, he's not sure. So this is permissible, but he has a great opportunity to learn. Somebody else like this one here have maybe 50% confidence, very good confidence, answering correctly. Few that are answered correctly, but he's not sure, and few answered wrongly, but again, he's not sure. And those are the ones that he has high confidence that he answered correctly, but they were wrong. Similar scenario for another person here. She got most of the answers correct, about 60%, not sure but wrong about maybe 10%, and unfortunately, high percentage, too high, 20% or so, 25% is sure, but unfortunately wrong. So this we can get for each resident, and actually each resident can define his limit and find out exactly where he is and where he need to learn more. And they are very good indicators for the education process. We can get a global picture also, something like this at the end of the program, and we can define the program is lying here or here, and this message will go to the program director so they can concentrate their efforts within that program on their teaching activities on certain issues. Now we only operating on within the sphere of universal topics, but we hope that this will be extended onto specifics for each rotation: thoracic rotation, vascular, cardiac surgery, ICU, and so on and so forth. And imagine that we can get everybody into the very good confidence and very good high score. Okay. So this is an example here for one of the items, let's say item number 70. Many people got it right, one with some doubt, and one with confidence, but unfortunately got it wrong. Otherwise, the majority here are reasonable. Another example is this one here. Many people got it wrong. Question number 11, many people got it wrong. With confidence, unfortunately. Only one person got it right with confidence, and some doubt. There is some doubt, but still got it wrong. Now, for each resident, this is the map that we can get. The initial response. Did anybody want to ask a question? All right, I'll continue. So for this particular resident, 46% of the responses were correct from the first time with very high confidence. So initial competence was very good. And then at the end, after correcting the responses, improve the unconscious incompetence from 20%, 21% to 0. So she gained quite a bit of confidence here. And at the end, she got all the answers correct, 100%. So this is the kind of response we'd like to see. Somebody get some wrong and then improve and then get all the answers correct. And therefore, this was a good learning experience for this resident. With that, I conclude, and I just wanted to give you this feedback so you know that we are looking at it on a weekly basis. and hopefully we can get you a very good guidance from this. This same exam will be repeated after 6 months, and then annually also we'll do it annually every twice a year, and it will encompass different rotations in 2-3 years. Hopefully we'll cover all the topics and all the rotations. I wish you all the good lucks. Any questions?
So the deadline, Dr. Farid, is 4th of March for now, right?
Actually, we gave 3 weeks, so or 4 weeks. It should finish by before March. So I think it will be 28th or something of February. I'm not really sure of the exact date, but please, yeah, it doesn't take much time. If you do it, you can do it all in one weekend. We're not encouraging you to do that, but learn from each question. Try to learn each question. One of the guys had done beautifully, very good response from the first time. He doesn't have to spend much time rereading and re-answering some of the questions. So, and another person have done actually the whole test already, finish it in about 3 hours or 4 hours. So it's a very good learning experience. We encourage all of you to do it. You should have received an email if you haven't done any activities, as well as your program director should have received something there to see how your compliance is. Thank you. Any other questions? Okay, Luai, you can take it from here.
Thank you, Dr. Farid. I'm not sure Dr. Faisal Lamri is with us.
I can cover with you for a short period of time if you wish.
Yeah. Ahmed, you can.
I am here. Yes, thank you.
Yeah, thank you.
I am honored, and I'm honored to be called to this activity, and we hope today we will have a nice lecture and review, and we'll learn something. To start with, I just want you guys decide about, or Ahmed also, if you guys want to present everything and we'll talk after, or you want me to stop in every point and then discuss. It's up to you.
For me, shukran Faisal, jazakallah khair. Thank you very much for coming and participating. Farid.
تسلم يا دكتور فريد، ما في مشكلة.
First, thank you, Dr. Faisal, for supervising me in this presentation. And it's fine for me if you want to comment on any point.
But yes, but do you want to finish everything and then we comment after, or do you want me to stop on everyone? It's up to you.
It's okay. You can stop me on any point.
Okay. Yalla, go ahead. Bismillah.
Okay. Good afternoon, everybody. Today, inshallah, I will be speaking about tricuspid valve regurgitation and stenosis. So, as an introduction, the disease of tricuspid valve can be divided into congenital and acquired. In tricuspid regurg, we can divide it into primary, which is related to pathology of the tricuspid valve itself, or secondary, which is related to left-sided heart disease, or isolated without left-sided heart disease and with atrial fibrillation. So tricuspid regurg is often incidental finding on routine echocardiography and assessment for the left heart during assessment of left heart valves. Most commonly, the tricuspid regurg, it's most commonly occurred due to left-sided heart valve disease, in particular mitral valve disease, with reported frequencies of primary TR from 8 to 10%, and the secondary TR, which is the predominant mechanism, in more than 90%. So these are my objectives. I will go through the anatomy of tricuspid valve regurgitation and stenosis etiology, clinical features, and evaluation. So to start with the anatomy, the tricuspid valve positioned between the right atrium and the right ventricle, and it builds the structural unit with the annulus, cord tendony, and the papillary muscles. Its orifice, in comparing it with mitral valve, is larger, and the leaflets and cord tendony are thinner and more translucent. There are no well-defined annulus as in the mitral valve. So the microscopic structures for the tricuspid valve is the annulus, leaflets, and the cord tendony. For the annulus, it has a complex shape and it does not conform to a flat ring. It built part of the triangle of Koch with the coronary sinus and tendon of Tudaro. This triangle is important during a tricuspid valve surgery because it incorporates the conduction system in it. Leaflets. We have 3 leaflets in the tricuspid valve: anterior, septal, and posterior. The anterior leaflet, which is the largest one, and it stretches from the infundibular area down to the inferior lateral wall of the right ventricle. The septal leaflet attached to both membranous and muscular portion of the ventricular septum, and the posterior leaflet, which is the smallest, and attached to the tricuspid ring along its posterior inferior border. The last one, which is the cord tendony, the cord attached to the anterior leaflet rise from the anterior and medial papillary muscles, and the cord attached to the posterior leaflet rise from the posterior and anterior papillary muscles, and the cord attached to the septal leaflet arises from the posterior and septal papillary muscles. So moving to the microscopic structures, against the same annulus, leaflets, and the chordae. The annulus formed from fibrous structure. The leaflets composed of fiber skeleton and endocardial surface, and the cord tendony is composed of network of collagen fibrils. So tricuspid regurgitation, the etiology.
Ahmed, can I stop you there, please?
Yeah.
Okay, so this is your presentation for the anatomy. Can you go back, please, to the first slide, the anatomy?
Sure.
I want this lecture to be more interactive, so other people can also please weigh in if they have any comment or any question during the anatomy. So you define all the chordae, the structure of the tricuspid valve, which is called, including the annulus, chordae, and the papillary muscle, and the leaflet, of course. Yeah. One thing that is missing is the position of the tricuspid valve. So if I ask if anybody knows, where is the tricuspid valve position in relation to the other valves?
Mm-hmm.
In particular to the mitral valve.
Is it anterior and
No,
right?
to the mitral valve.
It's down. It's more apical than the mitral.
So what's this is ayat or Amin?
Yeah.
Ayat, what is this, the importance of this?
I'm not sure.
Okay, anybody else? What's the, so ayat tells that the tricuspid valve is below the mitral valve. It's more apical toward the apex than the mitral. So what's the importance of this?
To differentiate between the normal and the Epstein anomaly.
Okay, but the Epstein will be more, so how do you know Epstein in a state of normal tricuspid?
It will be more than 8 millimeter away from the mitral.
Yeah, so it's more apical. So yes, so the Epstein is more apical than normal, but it's not. So what's the importance of the tricuspid is below the mitral?
There could be a communication between the left ventricle and the right atrium.
Yes, thank you. So any VSD, yes, no, No, any defect between the so the LV and RA could be happens, huh? Yeah, in this level. And so the other one is the relationship of the aortic and the tricuspid valve. So what's the relation of the aortic to the tricuspid valve? So let's say the membranous septum, where is it in the aortic valve? Guys, anybody? Membranous septum. Where is the membranous septum in the aortic valve?
Between the right and non-coronary sinus.
Okay, so any defect in there, where is gonna end in the right side? طيب, this is very important. So you have to review. You have to review all of this, huh? Okay. So the VSD between the left ventricle and the right atrium, it's called what? في واحد قالها قبل شوي.
Gerbody effect.
Okay, very good. So this is very important because it's always shown in the exam and also very important to all surgeons in case of post-AVR or infective endocarditis in the tricuspid also. طيب, this is very important aspect, and we know. طيب, a triangle of Koch. Can you go back to that? Yeah, triangle of Koch is bounded by what?
It's by the coronary sinus and the tricuspid annulus and the tendon of Todaro.
The annulus of what? That tricuspid valve annulus?
Yes.
What part of annulus?
I'm not sure.
Anterior septum of the tricuspid.
Anterior
leaflet, I mean, sorry.
Anterior leaflet?
Septal leaflet.
Septal or anterior?
It is the
Septal.
It's the septal. It's the septal part of the tricuspid annulus.
I mean, Dr. Al-Amri, isn't it the anterior? It's the septal, and we have the posterior, right?
No, it's anterior leaflet, and posterior, and then septal. So the septal is the annulus, the septal annulus. Where is the septal is, I mean, attached to the annulus. Part of it is doing the part of the triangle of Koch, and the other one is the coronary sinus. So the base of the coronary sinus, and the longest arm is done by ligament of Todaro. Ligament of Todaro is what? شباب, أحد يعرف ligament of Todaro is what?
It's a continuation of the IVC valve.
IVC
IVC valve.
IVC valve اسمه
The Eustachian valve.
Fold.
Eustachian valve.
Okay, and
Yes, it's a continuation of that, the fold of that.
So it's a fibrous fold formed between ايش وايش?
The smooth and rough area of the right atrium.
No. This is يعني يا شباب, this is very this is anatomy, and you are a surgeon and you have to know this. This is basic. You have to know this. So it's between the Eustachian valve and the trapezium valve. So, and those are valves of what?
The coronary sinus.
And
the IVC.
And inferior vena cava. So inferior vena cava, the Eustachian valve, and the trapezium valve حق coronary sinus. This is a fold, a fibrous tissue. This is the continuation between those two, and this is made. And you're gonna see it as a fold. You can see it actually. But in top of that triangle, there is ايش؟ AV node, صح؟
Yeah.
AV node. طيب. this is in regard لهذا. طيب more toward more اللي هو الانيولس of the tricuspid valve is what saddle shape صح؟ It's not circular, it's a saddle shape.
Yes.
طيب, if we have any dilatation, where do you expect the dilatation will be?
We're going anterior and septal.
Anybody else? Anybody else?
Mostly along the posterior.
Mostly in the posterior. Anybody else? طيب مين قال posterior؟
أنا حسين قطان recently graduated من البروجرام.
طيب حسين, what is in the posterior? إيش في هنا؟ Posterior leaflet. What do we call that part of the RV? طيب, we call it the free wall, صح؟
Yes.
طيب. So why? So مين اللي قال السبتل؟
Yes, Dr. Ahmed.
أحمد, طيب why septal? What's the septal? What's behind the septal?
Behind the septal is the.
Okay, let me cut it. So to just cut it in short. So usually the what happened to the tricuspid annulus is dilatation at the weakest part. Always remember, any dilatation of anything, including the valves, it's always happen at the weakest part. So the weakest part of the tricuspid valve is the free wall, not the septal. Why, Ahmed?
Because the septum is attached to the septal leaflet attached to the septum itself. So, يعني I would say that
إيش الستراكشر اللي هناك of the heart?
The septum.
Not the septum.
أيوة. The fibrous skeleton.
Yes, the fibrous skeleton. The mitral valve. What's usually happened in the dilatation? Posterior or anterior?
Posterior.
Posterior, because it's muscle, and anterior. Why not?
Because the intertrigonal area is held by the fibrous skeleton.
Yes, thank you. معناته, if we have any dilatation in the tricuspid valve, it's going to happen where? Antero-posterior, at the free wall. يعني half of the anterior and mostly almost the posterior part. This is very important. That's why one of the reasons we have a C shape or incomplete ring to put on the tricuspid is because we think is mostly the dilatation happened in those parts, and also to avoid the conduction system. So two reasons why we use C shape, because the septal part usually, it's not always, but usually it's supported by the fibrous skeleton, and the dilatation always happen in the anterior. طيب, okay. One distinctive feature of the tricuspid valve is how we can distinguish between tricuspid and mitral valve. Very important, ya shabab. You have to know, because when you do pediatrics in situs inversus and or in cordus between the two ventricle, you're gonna have to judge where is the RV from the LV, and sometimes it's hard. And so you have to know where is the tricuspid valve and the mitral valve. So there is distinguish feature between each one. You have to know about it. طيب. One of them is the septal attachment of the إيش؟ of the أحمد اللي قالها تو, قال إيش septal leaflets is always attached to the septal إيش؟ attachment to the septum, صح?
Yes.
طيب. This is the most important things about the tricuspid anatomy you have to know. Okay, go ahead, Ahmed.
Sure, thank you, Dr. Faisal. So moving to the etiology of tricuspid regurgitation, we can classify it into three. Presence of primary tricuspid valve pathology, which is the primary tricuspid regurg. Presence of associated left-sided heart disease is secondary TR. Presence of atrial fibrillation without associated left-sided heart disease. This is isolated tricuspid regurg. So in primary tricuspid regurg, which is caused by abnormality of the tricuspid valve or its subvalvular apparatus, including the leaflets, chordae, papillary muscle, or annulus, due to congenital or acquired causes. So to start with the acquired causes, we have tumors like carcinoid disease, myxoma, drug-induced, ergot alkaloids and dopamine agonists, iatrogenic injury, transvenous pacing or defibrillator leads, endomyocardial biopsy, and endocarditis. Systemic diseases such as lupus erythematosus, sarcoidosis, radiation, rheumatic disease, trauma, and presence of transvenous leads traversing the tricuspid valve. So in rheumatic disease, the tricuspid valve affected after the mitral and aortic valves. The leaflets become thick, fibrotic, retracted without commissural fusion, and it can also involve the chordae, causing restriction of the leaflets. Finally, it will cause tricuspid stenosis and regurg, with regurgitation will be the predominant. In myxomatous or degenerative diseases, the myxomatous process involving the leaflets, chordae, and the annulus. So the myxomatous related, the myxomatous process will cause annular dilation and will contribute to the degree of tricuspid regurg. The majority of isolated myxomatous tricuspid valve occur in patients who previously underwent left-sided surgery, and the prognosis for these patients, or for those patients, will be related to the RV function and pulmonary hypertension. Endocarditis. Bacterial endocarditis can destroy or even perforate the leaflets and rupture the chordae. Vegetation, which can be seen also may be associated with stenosis and regurgitation. So the prognosis in this case will depend on the degree of valvular damage, abscess formation, right ventricular failure, embolization, and the causative organism. So rarely culture-negative organisms, such as Triphorema wepeli, which can cause restriction of leaflets, can cause tricuspid regurg. This restriction is associated with either stenosis or regurg that may resolve with appropriate antibiotic treatment. Sarcoidosis, it's a rare cause of tricuspid regurg. Granulomas has been found in the annular region and
معلش يا احمد نوقف هنا شويه ارجع للفيرست كوز. So why we have to know the cause?
So we can intervene or treat. It's depend on the we'll know the pathology, what will happen, so we can intervene either medical or surgical.
So we can decide decision about surgery and treating underlying disease.
Yes.
And planning the surgery. So planning the surgery is depend on the cause. So yes. It's very important. لأنه secondary is more toward annular dilatation. Primary more leaflets problem. So when you go, the ring, like if you have a rheumatic, the ring enough, the ring will not gonna be enough. So you know there is a leaflet problem. Then you start to examine the leaflet and then, decide whether you're going to do commissurotomy or you are going to replace, whatever. So it's very important to know the underlying cause because of this. As you mentioned, rheumatic is part of the disease. It's uncommon to have a rheumatic valve, and the tricuspid is mostly to the left side, as we know. Mitral, then aortic, mitral, and then aortic, and then tricuspid. But it has been seen, and it's part of the problem sometimes. Okay, and then the next one is you went to the myxomatous or degenerative, very rare, but it happens with the old age, as it happened to the mitral valve. Okay, next one is the endocarditis. Endocarditis is very important in which subtype of group? In tricuspid valve.
IV drug users.
IV drug users. What is the most common organism?
Pseudomonas.
Huh?
Staph aureus.
I'm sorry?
Staph aureus.
Staph aureus, because it's a skin. So IV drug user is using the skin. So always Staph aureus is the problem in those patients. What else other than IV drug? Alhamdulillah, it's not a lot of people.
Can I comment, Doctor? Because the most common in tricuspid valve is gram-negative, and mostly in Pseudomonas.
And where did you find that?
In Kirkland book.
طيب, can you find it in the in the other? Show it to me on the like a paper.
Yeah, I will send it in our group, in WhatsApp group.
خلاص, you will do it and then send it to the group. What other people? What other condition that we have other than IV drug user? Also common in
hemodialysis. Hemodialysis.
Yes, because there is a lot of instrumentation. So we have hemodialysis patient. They have also can affected with endocarditis. طيب, what else? Okay, next. Okay, you can start with the sarcoidosis.
So in sarcoidosis, it's a rare cause of tricuspid regurg. Granulomas has been found in the annular region and the papillary muscle and on the leaflets. And the hallmark of cardiac sarcoids include conduction system disease and widespread left and right ventricular scarring. In SLE, approximately half patients who have SLE have a cardiac involvement, either myocardium, pericardium, coronary arteries, and valves. So patients who have a cardiac involvement, valves are involved in 40% of them. Tricuspid valve are much less likely to be involved than left-sided valves, and the prognosis depend on the controlling of the underlying disease. Implemented into endocardial electrical devices, permanent pacing and ICD leads associated with increased risk of tricuspid regurg. And the pathology includes fibrosis and fusion of wire to the leaflet and the subvalvular structures. Carcinoid. Due to high circulating hormone levels, mainly serotonin, impact on the heart lead to most commonly valvular fibrosis. It can cause thickening, retraction, shortening, hypermobility, and rigid leaflets. The carcinoid lesions are not known to regress, even with control of the disease. Ergot alkaloids and phenfluramine.
أحمد, معلش نرجع للكارسينويد شوية.
Yeah, sure.
طيب, very rare condition, صحيح?
Yes.
It happens always with serotonin, with other hormones, as you said. There is a lot of hormones can affect the also the like الhistamine prostaglandins and a lot of problems. طيب but the carcinoid يعني what's this the usual feature of the carcinoid in the tricuspid valve?
I would say that the thickening and rigidity of the leaflets.
في characteristic feature in the echo ولا in the OR that you can tell, oh, this is a carcinoid?
I'm not sure exactly about.
Anybody else? Anybody else, guys? ما في أحد؟ طيب.
The leaflet will be thick and involve the chordae as well, and it's affect the ventricular surface of the tricuspid valve and the pulmonary valve.
Okay. لا بس this is all feature of rheumatic also, صح؟
Yes.
بس في distinguish هذا very distinctive feature about هذا. في شيء اسمه black، صح؟ fibrous black. في الكارسينويد there is a fibrous black always happen on the زي ما قلت على usually at the endometrium of the RV. فنشوفها في الإيكو as a thickening of the RV endometrium، أو نشوفها also in the ventricular surface of the tricuspid valve، أو على الannulus or على chordae على الpapillary. This is the distinctive feature about the carcinoid. Always a black that is fibrous, looking like fibrous. طيب. The most affected valve, as you said, is the tricuspid and followed by the pulmonary. So carcinoid, when did this happen? I mean, carcinoid, does all the patient with carcinoid comes with the RV feature?
I would say no, but I don't know why.
أيوة, it's no, صحيح. It's 20% usually or less. Why? Because the liver can deactivate الإيش؟ الcarcinoid hormone, always serotonin and the other hormones always deactivated by the liver. So whenever you have a heart involvement, that means the carcinoid are in the liver, or it's in the lungs, or it's in the liver, it's a metastasized, like it's a huge one. Because with this amount of hormones that is produced, it's not deactivated by the liver. That means it's a lot. So whenever you see cardiac involvement, this is usually a metastasized carcinoid to the liver. If I ask you why it's always left, right, not more than left?
Because it's deactivated by the lung.
Oh, excellent. So also the lungs does the same thing, so they can deactivate. So that's why usually the right side is more affected than the left. Okay, good. We can move on.
So for ergot alkaloids and phenfluramine, cabergoline used for treatment in pituitary tumors, and the pergolide used for Parkinson's disease, also associated with carcinoid like valvular pathology. The effect of this agent on tricuspid valve is related to the dose and duration of exposure. This it can cause thickening of chordae and the papillary muscles. With the phenfluramine, the incidence of tricuspid valve involvement is less than the left side, in average 2 to 12%. Radiation In series of 415 Hodgkin lymphoma survivors, 6.2% developed moderate to severe valvular disease. Mean time from radiation of 22 years observed, and the etiology of tricuspid regurg related to the radiation-induced alteration in the right ventricular function and left ventricular systolic or diastolic function, and the pulmonary hypertension. Blunt trauma, usually motor vehicle accident. This can cause acute compression, rapid elevation in the right ventricular pressure, and there can be leaflet tear, anterior papillary muscle damage with immediate or delay heart failure symptoms, or chordal rupture. So suspicion and close follow-up and early surgery in the setting of acute right ventricular failure can lead to better outcomes. Congenital defects, Wettstein anomaly, account for 39 to 70% of congenital patients undergoing isolated tricuspid valve surgery. Other congenital lesions, including tricuspid valve hypoplasia and dysplasia. Moving to causes of annular pathology without involvement of the right ventricular alteration or pulmonary hypertension. So in addition to sarcoidosis and myxomatous diseases, including connective tissue disease like Ehlers-Danlos and Marfan, the atrial fibrillation can cause annular dilation and a tricuspid regurgitation. So in atrial fibrillation, the clinical features include advanced age, female sex, systemic hypertension, a greater RA than LA enlargement, and lower systemic pulmonary artery pressure. Endocardial fibroelastosis, it's generally associated with high eosinophil count, and both sides of heart can be involved. This can cause right ventricular, endocardium, papillary muscle, chordae, and tricuspid leaflet fibrosis, valve restriction with either significant regurg or stenosis. The treatment of underlying disease that cause eosinophilia can lead to improvement in valve function if treatment is initiated before the permanent damage. Endomyocardial biopsy. This is well established as a gold standard for evaluation of possible rejection episode after cardiac transplantation. The tricuspid valve apparatus will be at high risk of injury during this procedure. Renal and ovarian tumors. These tumors can grow into the tricuspid orifice, creating stenosis or regurgitation. Atrial myxoma also could impinge upon the valve and cause severe annular distortion and tricuspid regurg. So the treatment is directed to the tumor and generally include excision. So moving to the secondary tricuspid regurg, which is the presence of associated left-sided heart disease. The mechanism in the secondary tricuspid regurg characterized by RV dilation and dysfunction. This will lead to a leaflet tethering, tricuspid annulus dilation, and leaflet malcoaptation. This is most common caused by significant left-sided valvular and myocardial disease, and that lead to increased left-sided pressure, pulmonary hypertension, increased RV afterload, and remodeling of the RV. So in patients with mitral regurgitation, almost 25% will have moderate to severe tricuspid regurg, And in severe aortic stenosis, almost 40% will have a moderate to severe tricuspid regurg. Causes of pulmonary hypertension may include pulmonary embolism and chronic pulmonary disease. It's similar. It will lead to increase the RV afterload and RV remodeling and dysfunction. So in absence of pulmonary hypertension, intrinsic RV disease such arrhythmogenic RV cardiomyopathy and myocardial ischemia can lead to tricuspid regurg through papillary muscle displacement, increased tethering of the TV leaflet, and leaflet malcoaptation. So moving to the third part, which is the isolated tricuspid regurg. So in isolated TR, this is a novel entity most frequently seen in elderly patients with atrial fibrillation in absence of concomitant pulmonary hypertension or coexisting left-sided heart disease. The underlying mechanism is right atrial and tricuspid annular dilation, leading to leaflet malcoaptation in absence of any RV remodeling. So moving to tricuspid stenosis, there are several etiologies for tricuspid stenosis, with most commonly is rheumatic heart disease. It's commonly seen in association with mitral stenosis or with both aortic and mitral stenosis. So tricuspid stenosis can be due to, as I said, rheumatic disease, congenital anomalies, like a Bestian anomaly or isolated tricuspid valve stenosis, metabolic disorders like Farb's disease, Whipple's disease, and Carcinoid. Also, it can be due to infective endocarditis. So stenotic tricuspid valve found to have thickening of the leaflets with shortening and thickening of the chordae tendineae. So fusion of the commutures lead to obstruction of the flow. Congenital heart disease may cause tricuspid stenosis by a variety of mechanisms: incompletely developed leaflets, shortened or malformed chordae, small annulus, or abnormal number or size of papillary muscles. A Bestian anomaly typically results in tricuspid regurg, but can also lead to tricuspid stenosis in patients with leaflets that remain fused. So a clinical feature of tricuspid regurg and stenosis, tricuspid valve disease usually brought to the attention during evaluation of left-sided heart disease. Frequently, those patients present with dyspnea on exertion, orthopnea, and symptoms of left-sided heart failure. And in advanced cases, patient may have proximal nocturnal dyspnea. It may occur. So the signs, the patient may have jugular venous distension, pleural effusion, ascites, peripheral edema. Patient also may complain of vague abdominal pain, which is associated with hepatomegaly. In evaluation, echocardiography is the gold standard, and catheterization is no longer used for evaluating the severity of tricuspid stenosis. So there is no generally accepted grading for tricuspid stenosis severity, but mean gradient of 5 mmHg and more at a normal heart rate is considered indicative for clinically significant tricuspid stenosis. Evaluation of tricuspid regurg severity, it includes integration of multiple quantitative and qualitative parameters and the pulmonary systolic pressure. So by this slide, I conclude my presentation, and thank you so much. And thank you, Dr. Faisal, for the comments.
Any questions, Shabab? Comment? No question, no comment? Okay, Ahmed, a very good presentation. Only if you have the physiology and pathophysiology of the right side parameters will be perfect and will be completed with this presentation. The importance of this is very crucial in the decision for understanding the mechanism of the disease. RV, RA, the hepatic veins, the pulmonary artery pressure, all this is very important for decision and for understanding the underlying cause and disease. And if the intervention will benefit the patient or not, and the timing of the intervention is very important regarding all of this. As you say, secondary disease is the most common pathophysiology affecting the tricuspid. It usually dilates the annulus, but be careful, always there is a tethering. So sometimes if you put a ring only, this is not going to take the tricuspid Regerg away, but mostly it will. So understanding the mechanism is very important, and also the pressure in each compartment is very important. So you will know what's the cause of this. As you said, left side disease usually bring pulmonary artery pressure high, and that can lead to dilatation and of the RV, and then the annulus will dilate. Those pathophysiology and physiology of the right side is very important, ya Shabab. Okay?
Yes, sure, Doctor.
What's your second من اللي حقدم what you guys gonna propose next talking?
النكست دكتور بيكون الدكتور رياض الحارثي بيقدم ال latest American Heart Association Tricuspid Valve Guidelines for Tricuspid Stenosis and Regerg.
Okay, good. خلاص so we don't have to go through this لأنه رياض حيقدم التوبكس هذه. بس always remember إنك you understand what is the risk of tricuspid valve repair as isolated, as not isolated. Why tricuspid valve surgery always carries a high risk, especially after left side surgery, or as isolated, is very important. So you understand when to intervene. And if anybody has a question about this regard, he can always ask or contact me. Or this is very important, عشان to understand the whole picture of the tricuspid valve. The last thing is مين هو الشاب اللي قبل شوي قال الموست كومن IV drug؟ مين هو؟
عبد العزيز الشمري.
عبد العزيز. طيب ديزي لقي السورس حقه؟
اي نعم موجود دكتور في الجروب.
في أي جروب؟ طب ليش ما تسوي له شيرينج معنا هنا؟
لأنه المشكلة الكتاب نفسه ما هو موجود عندي في الكمبيوتر هنا.
طيب ايش هو الجروب؟ قل لي عليه عشان انا اول مره اسمع ان جرام نيجاتيف is the most common cause of infective endocarditis. لو اي ممكن تفتح لنا على جوجل وتسوي لنا most common in IV drug user في الترايكاسبيد.
عبد العزيز انا فاتح كيركلين.
ايوه روح لصفحه 658.
مين في احد ثاني؟ احمد.
يس دكتور.
افتح لنا IV drug user in tricuspid valve please. Endocarditis في جوجل.
لا هي اكيد الستاف اوريوس. I'm going with the staph aureus.
ايوه هنا دكتور معلش. شوف
أيوة.
ايوه شوفها موجوده في tricuspid valve endocarditis.
Is a rare and usually associated with intravenous self-administration of the most common. هذا مثل هذا Pseudomonas.
ايوه الكتاب دكتور.
are going to be followed by staph aureus. A variety of. كم هذا طبعة كم؟
I think انه 2014 or something like this.
It's very rare لأنه all the paper if you go around it's always Staphylococcus aureus is the most common. Because it's a skin flora, always this is the cause of the entrance of this. Because somebody, when you inject somebody, بتاخد skin flora within the tip of the needles, and also when you go through another guy, so you're gonna transfer the same هذا. خصوصا مع now the prevalence of the MRSA is increasing. Now is the MRSA also become on the top of all pathogens that can lead to infective endocarditis. But and I'm surprised صراحة إنه كاتبين Pseudomonas, because always when you go to the literature it's always شو اسمه the Staphylococcus aureus is the number one for the IV drug user. طيب.
Okay.
So if you guys who can does يعني زي ما يقولوا research on the literature عشان find out who's هذا, وبعدين they can share it with us later on.
I did quick research on Google and UpToDate and Medscape. All they are saying staph aureus is the most common.
Yes, this is the one. عشان كذا I'm very surprised مع Kirkland إنه always said Pseudomonas. In general, دائما if you ask what is the most common organism, try to put 3. If the exam you said Pseudomonas, staph, بعدين stript, ممكن أمشيها. لكن if you told me Pseudomonas and it's very weird pathogen, ممكن يسوي كذا. always when somebody asks you what's the most common هذا, حط 2 or 3, so you'll be at least saved. يعني if you said Pseudomonas بعدين staph بعدين stript, يعني it's not a big deal. بس لما تقول Pseudomonas only, this is very weird. هذا. طيب, there is any question, any comment? خلاص طيب. طيب أنا I think that's all my rule, and I hope you guys have a nice day and a nice lecture.
Thank you, Dr. Faisal again.
Thank you, Dr. Faisal. Thank you.
Okay, thank you, Ahmed and Dr. Faisal, for this informative session. So we'll have a break for 10 minutes and we'll start with the second lecture.
Hello, 18 minutes?
Yes.
Okay, thank you.
السلام عليكم.
وعليكم السلام ورحمة الله.
مين هذا أحمد؟
Yes, دكتور.
أقول لك مين اللي مسؤول عن attendance to this activity؟
ما أعرف والله، ممكن لؤي، مهند وعبد الملك، أتوقع الثلاثة هذول.
شكلهم في البريك كلهم دحين.
هذه دكتور فريد، السلام عليكم، يعطيك العافيه.
هلا هلا الله يحييك.
عبد الملك يقدر من الزوم يشوف كل اللي حضروا، يعني at the end of the session
ايوه
يخلص في برنت اوت كنا نطلعه، فاكيد
ايوه انا هذا قصدي، يعني اللي مسؤول عنهم لازم يرسل لانه الحضور في عدد معين. اظن كم احنا قلنا من زمان 40 ولا كده 42 42 اظن شو اسمه ده 42 ميتنج، فحيكون ال 70% تقريبا 30 او 32. So they have to report it every month and send it to the maybe to the program directors or to إيمان ولا كده.
هذه مع فيصل شمدين، يعني هو اكيد مع النيو تيم اكيد عندهم كل التفاصيل.
يعني فيصل اظن رايح اجازه اليوم، بس ماني داري اذا هو موجود ولا لا. بس كويس الواحد
موجود all printed all documented everything.
جزاكم الله خير. انا شايف ما شاء الله العدد بيتناقص. انا شايف دحين اليوم حاضرين 30 او 33، العدد حقكم مكتوب 54 واحد في الهيئه. ما
وصلنا الوقت كان في الفورتيز، بس يمكن الناس طلعت قبل عشان بريك.
اوكي، مو عشان دبي ولا هذه الايام ما في دبي.
ما في دكتور،
ما في.
الله يعيني والله
على يدك دكتور.
بس كويس انه يسمع الواحد صوت هيثم يذكرنا بالذي مضى على قولك.
الله يعطيك العافيه.
الله بالتوفيق ان شاء الله. على فكره جاءت كلام على الاندوكاردايتس السورس اوف سودوموناس. من فين يجي السودوموناس يا عبد العزيز؟ ولا هو هيز ان بريك اولسو؟
لا موجود دكتور. he's gram negative. I'm not sure from where.
من فين يجي؟ مرة سوينا دراسة في التخصصي.
دكتور فريد اقدر اجاوب؟
اتفضل.
يجي من الووتر. معظمهم هذول they use the drug injection in the bathroom and they wash it with regular water, so it's in the water.
مو regular water، لا بيستعملوا حقة نفس شو يسموه هو الكرسي حق الحمام.
اي
استعملوا من هناك. فطبعا this is contaminated usually with gram negative. بس حتى الصابون اللي في الحمام على فكرة، الصابون القطع الصابون اللي تيجي كده زي لوكس وما لوكس ومش عارف ايه. سوينا دراسة في التخصصي على نوعية الصابون اللي كانوا يستعملوها. كانوا يستعملوا كده صابون صغير أبيض في الحمامات، ولما سوينا الدراسة وجدنا إنه كل الصابون هذا infected with ولا infested with سودوموناس. ومبلبل تعرف كده وقاعد مزوي في الحمام، فتلاقيه always carry that organism. الله أشوف الشباب كلهم حنوا للمجلس هذا ما شاء الله. القدامى كلهم المخضرمين معاكم.
لسه وين مخضرمين؟ لسه متخرجين امس يا دكتور فريد.
يعني قبل امس بيوم.
ترى يوم واحد يفرق دحين، اكبر منك بيوم اعلم منك بسنه.
صحيح.
very nice session. يلا الله يوفق ان شاء الله.
الله يجزاك.
في اليوم جون كلابز ولا ما في؟
على الجد ولا ما في؟
يلا الله يوفق. في بعض الناس حطوا تعليقات على الأسئلة، تعليقات حلوة وجميلة على الأسئلة حقت الفورماتيف. ما أدري أنت يا أحمد سويت منها شيء، كيف فيها صعوبة، فيها challenges؟
ان شاء الله
فيها
يعني
فيها
يومين،
اخطاء ولا شيء؟
ان شاء الله اليومين هذه دكتور، يوم السبت ان شاء الله بعطيك رايي.
طيب.
الرياض.
السلام عليكم. رياض الحارثي at كفافة. I will talk about latest guideline of tricuspid valve at American College of Cardiology and American Heart Association. This is table for classification of class of recommendation and level of evidence. In class, we have class 1. This is benefit more higher than risk, and there is class 2A. It's benefit higher than risk, and class 2B benefit higher or equal than risk, and we have class 3 benefit equal risk, and class 3 harm, it's risk more than benefit. In the level, we have level A, B, and C. In the level A, it's highly quality evidence from more than one RCT, and the level B, we have randomized and non-randomized. And class C, we have limited data and expert opinion. Tricuspid regurgitation, this is classification and stage of TR. Trace to mild degree of TR of no physiological consequence are commonly detected on TTA in subject with anatomical normal valve. Worsening TR is associated with poor long-term outcomes. Most cases of significant TR are secondary, and this is table for classification of TR. This is primary and secondary. Primary, we have rheumatic infective endocarditis, iatrogenic defies lead or endomyocardial biopsy, congenital lesion or lymphotransposition of great artery, other like trauma, carcinoid, drug, and irradiation. As a secondary, we have pulmonary hypertension and RV remodeling, primary or secondary to left-sided heart disease, dilated cardiomyopathy, annular dilatation, and RV volume overload. This table for stages of TR, we have stage B, C, and D. Stage B, we have progress TR. In the valve hemodynamic, we can see central jet less than 50% of RA, vena contracta width less than 0.7 centimeters, ERO or effective regurgitant orifice less than 0.40 centimeters square, and regurgitant volume less than 45 millimeter. In hemodynamic consequence and clinical symptom, we can say none. In a stage of C, asymptomatic severe TR, and stage D, symptomatic severe TR, valve hemodynamics as the same. We can see central jet more than or equal 50% of RA, vena contracta width more than or equal 0.7, ERO more than or equal 0.40 centimeter square, regurgitant volume more than or equal 45 millimeter, dense continuous wave signal with triangular shape, and hepatic vein systolic flow reversal. In hemodynamic consequence, we can see in stage C and stage D at the same dilated RV and RA, elevated RA with C wave. At the clinical symptom, we can see in stage C elevated venous pressure, but we don't have symptom. And with the stage D, we have elevated venous pressure with dyspnea on exertion and fatigue, ascites, and edema. A symptomatic patient with severe TR stage C present with an elevated central venous pressure and imaging evidence of significant TR. Symptomatic patient with severe TR stage D have symptom of fatigue, abdominal clotting, and peripheral edema. End organ damage is an adverse consequence of stage D TR that markedly affect of survival. Diagnosis of TR stenosis TTA can determine the etiology TR and effect on RV. Cardiac catheterization is of clinical value of information from TTE is an inadequate or discordant with clinical presentation. TTA can distinguish from primary TR from secondary. Patient with TR undergoing left-sided valve surgery, an annular diastolic diameter more than 40 millimeter or 21 millimeter per meter square, indicate increased risk of persistent or progressive TR after isolated mitral valve surgery. Pulmonary artery systolic pressure is estimated from maximal TR velocity. Normal RV systolic function is defined by several parameters, including tricuspid annular plan systolic excursion more than 16 millimeter, tricuspid valve systolic annular velocity more than 10 centimeter per second, RV in systolic area less than 20 centimeter square, or fractional area change more than 35%. Other imaging modulator such as 3D TEE, MRI, and CT scan may provide more accurate information on the status of the RV. Invasive measurements are essential for patients in whom of the cause pulmonary hypertension is uncertain or when assessment of pulmonary vascular reactivity after vasodilator challenge is needed. Direct measurement of right atrial pressure may also be useful for clinical decision making. Right ventriculography to evaluate the severity of TR and status of RV. Thermodilation, cardiac output measurement may be inaccurate with severe TR. This is table for recommendation diagnosis of TR. Class 1 level of evidence C, limited data. We can say in patient with TR, TTA is indicated to evaluate the presence and severity of TR, determine the etiology, measure the size of right side chamber and inferior vena cava, assess RV systolic function, estimate pulmonary artery systolic pressure, and characterize any associated left-sided heart disease. In the class of recommendation 2A and level C, limited data. In patient with TR, invasive measurement of cardiac index, right side diastolic pressure, pulmonary artery pressure, and pulmonary vascular resistance, as well as right ventriculography, can be useful when clinical or and non-invasive data are discordant or inadequate. Medical therapy, diuretic therapy treat the systemic congestion in patients with severe symptomatic TR. Patients with secondary TR treatment underlying primary cause. Patients with severe TR usually present with sign or symptom of right side heart failure, low salt diet, and support stacking may be helpful. Diuretic can be used to decrease volume overload in this patient. Loop diuretic are typically provided and may relieve systemic congestion, but their use can be limited by worsening low flow syndrome. Aldosterone antagonists may be additive benefit, especially in setting of hepatic congestion, which may promote secondary hyperaldosteronism. Medical therapy for management of severe TR stage C and D are limited. Attention should be focused on underlying etiology in patients with secondary TR. Reduction of pulmonary artery pressure and pulmonary vascular resistance with specific pulmonary vasomodulator can be helpful to reduce RV afterload and secondary TR in selected patients with pulmonary hypertension. Guideline medical management therapy is effective for secondary TR attributable to heart failure with reduced left ventricular ejection fraction. Restoration of normal sinus rhythm may be effective for secondary TR attributable to annular dilatation associated with AF. This is table for recommendation medical therapy. Class of recommendation 2A, level C, expert opinion. We can see in patients with sign and symptom of right side heart failure attributable to severe TR stage C and D, diuretic can be useful. In class of recommendation 2A, level C, expert opinion in patients with sign and symptom of right side heart failure attributable to severe secondary TR stage C and D, therapy to treat the primary cause of heart failure, such as pulmonary vasodilator to reduce elevated pulmonary artery pressure. Guideline management therapy for heart failure with reduced ejection fraction, left ventricular, or rhythm control AF can be useful. Timing of intervention. Treatment of secondary TR is targeted at pulmonary hypertension or myocardial disease. Surgical treatment is performed for selected patients with TR at the time of surgery for left side valve lesion to treat severe TR stage C and stage D. And to prevent later development of severe TR in patients with progressive TR stage B. Intervention for severe isolated TR had high reported operative mortality rate up to 8 to 20%, but most of these interventions were performed after end organ damage. Outcome of patients with severe primary TR are poor with medical management. Severe TR may not improve predictable after treatment of left side valve lesion and reduction of RV afterload. Reoperation for severe isolated TR after left-sided valve surgery is associated with preoperative mortality rate 10 to 25%. Tricuspid valve repair is preferable to replacement. Left uncorrected at the time left side valve surgery, mild to moderate degree of secondary TR may progressive over time in approximately 25% of patients and result in reduced long-term functional outcome and survival. Patient
Riyadh, we cannot hear you.
Dr. Riyadh, we cannot hear you.
I think he has some issue. I'm trying to call him. Riyadh is not answering the phone. Just give him a few minutes to reconnect. Maybe having some online issue.
الو
Yes.
ما اعرف انا فين وصلت انا بالضبط.
Just one slide. You finished you.
Yes, I finished
Yes,
my
go back.
presentation. Did you see my screen now?
Yeah, you can. No, go next, not this one.
Next.
Yes, here I think timing of intervention.
Here. Okay. Intervention for severe isolated TR had a high reported operative mortality rate up to 8 to 20%, but most of these interventions were performed after end organ damage. Outcome of patients with severe primary TR are poor with medical management. Severe TR may not improve, predictable after treatment of the left-sided valve lesion and reduction of RV after load. Reoperation for severe isolated TR after left-sided valve surgery is associated with preoperative mortality rate of 10 to 25%. Tricuspid valve repair is preferable to replacement. Left uncorrected at time of left side valve surgery, mild to moderate degree of secondary TR may progress over time in approximately 25% of patients and result in reduced long-term functional outcome and survival. Patients with severe congestive hepatopathy may also benefit from surgery to prevent irreversible cirrhosis of the liver. Quality and duration of long-term survival are related to residual RV function. TR can develop in association with AF and annular. These patients with AF-related TR have rapid progress of TR severity and right side chamber dilation. Symptomatic patient with AF-related severe TR, quality of life and symptom can be improved by surgical intervention for TR. Patients with undergoing intervention overall outcome are better induced without severe RV dysfunction or end organ damage. Healthy patients without other comorbidity, the surgical risk associated with tricuspid valve operation is low, less than 1 to 2% operative mortality rate. This high reoperative mortality rate is likely related to evidence nature of RV failure. If there is no significant pulmonary hypertension or severe RV systolic dysfunction, operation for severe symptomatic isolated TR years after surgery for left-sided disease may improve symptomatic of right-side heart failure. This table recommendation for timing intervention, class 1, in patients with severe TR stage C and D undergoing left side valve surgery, tricuspid valve surgery is recommended. And class 2A, level B, non-randomized in patients with progressive TR stage B undergoing left-sided valve surgery. Tricuspid valve surgery can be beneficial in context of either one tricuspid annular dilatation, tricuspid annulus, in diastolic diameter more than 4 cm or 2 prior sign and symptom of right side heart failure. Class 2A, level B, non-randomized in patients with sign and symptom of right side heart failure and severe primary TR stage D. Isolated tricuspid valve surgery can be beneficial to reduce symptom and recurrent hospitalization. Class 2A, level B, non-randomized in patient with sign and symptom of right side heart failure and severe isolated secondary TR attributable to annular dilation in the absence of pulmonary hypertension or left-sided disease, who are poorly responsive to medical therapy stage D. Isolated tricuspid valve surgery can be beneficial to reduce symptom and recurrent hospitalization. Class 2B, level C, limited data in asymptomatic patient with severe primary TR stage C and progressive RV dilation or systolic dysfunction. Isolated tricuspid valve surgery may be considered. In class 2B, level B, non-randomized in patients with sign and symptom of right-sided heart failure and severe TR stage D who have undergone previous left-side valve surgery reoperation with isolated tricuspid valve surgery may be considered in absence of severe pulmonary hypertension or severe RV systolic dysfunction. This is of indication surgery of tricuspid regurgitation. We have progressive TR stage B and severe TR stage C and D. With progressive TR stage B, at the time of left-sided valve surgery, annular dilatation more than 4 cm or prior right heart failure, surgery class 2A. With severe TR, at the time of left-sided valve surgery, class A. With severe TR stage C and D, we have asymptomatic stage C and right heart failure stage D with asymptomatic primary TR with progressive RV dilation or systolic dysfunction, surgery class 2B. With right heart failure, we have a primary, secondary, and prior left-sided valve surgery. At the primary, we can do surgery class 2A with secondary and poorly responsive to guideline management therapy, annular dilatation without increased pulmonary artery pressure or left-side disease. We can do surgery class 2A. Prior left-side valve surgery, absence of severe pulmonary hypertension or RV systolic dysfunction, surgery class 2B. Tricuspid stenosis. This is from American College of Cardiology at 2014. This is stages of severe TS, stage C and D. Valve anatomy, there is a thickened and disordered calcified leaflet, a valve hemodynamic pressure half time more than or equal 190 millisecond, valve area less than 1 centimeter square, hemodynamic consequence RA and IVC enlargement, and with symptom none or variable and dependent on severity of associated valve disease and degree of obstruction. Diagnosis and follow-up. Class 1 TTE is indicated in patients with TS to assess anatomy of the valve complex, evaluate severity of stenosis, characterize any associated regurgitation and or left side valve disease. Level of evidence C. Class 2B invasive hemodynamic assessment of severity of TS may be considered in symptomatic patient when clinical and non-invasive data are discordant. Level of evidence C. Medical therapy, loop diuretic useful to relieve systemic and hepatic congestion in patients with severe symptomatic TS, although their use may be limited by worsening low flow syndrome. Attention to left side valve disease and AF when present is also important. Intervention. Class 1 tricuspid valve surgery is recommended for patients with severe TS at the time of operation for left-sided valve disease. Level of evidence C. Tricuspid surgery is recommended for patients with isolated symptomatic severe TS. Level of evidence C. Class 2B percutaneous balloon tricuspid chemotherapy may be considered in patients with isolated symptomatic severe TS without a combined TR. Level of evidence C. This is my reference, American Heart Association guideline, management of patients with valvular heart disease at 2014 and 2020. Thank you.
Okay, thank you, Riyadh. Any question or comment for Riyadh? I believe Dr. Faisal has left already. I think Dr. Farid is around. Any comment, Dr. Farid, from your side? Okay. So as I mentioned earlier, Dr. Halis is busy, so he will not be able to present to us today. So his lecture will be scheduled for another date. So for next week, we have tricuspid valve repair and replacement and multiple valve disease. So for the presenters, please, if you can manage to arrange with one of the consultants to be with us, or you can contact me if you have any problems so we can arrange together. So by this, we'll conclude our session for today. Thank you.